And here's what I think of as one of the paragons of how you might, first of all, a paragon of healthcare delivery systems, but also an example of how you might use this information, although they wouldn't call it comparative effectiveness research. This is congressional testimony by Glenn Steele, who is the CEO of Geisinger Clinic in Pennsylvania. And he talks about how they changed their payment system. And one of the things about Geisinger is they are a provider group, but they also have an insurance product and have something on the order of 100,000 covered lives in their own insurance plan. So they don't have to negotiate with an insurer, at least for that group of people. They could make the rules. So what he says they did is the cardiology service line looked at the authoritative guidelines for cardiac surgery, and they translated this into some very practical steps that they could put into order sets. So they're using an evidence-based approach to decide what should be done routinely in these cases, put it in the electronic health record, and then they established a package price for the services. So instead of billing for every individual service that's done in hospitalization, they actually bundled together all the hospital costs for the surgery and related care for 90 days after, et cetera, et cetera. What I want you to notice is that they didn't just arbitrarily decide what would go in this bundle. They're basing it on evidence, and the comparative effectiveness research is intended to give people the information about what should go into these bundles of care in various cases. So this is one of the reasons the Lewin group actually said you could get $368 billion in savings over 10 years from comparative effectiveness research. I didn't put it on here, but CBO basically estimated no savings whatsoever from comparative effectiveness research. But when they did it, their estimates were based on a particular congressional bill that wasn't actually passed into law, but this bill said this information cannot be used to set coverage or in any way to change payment. So of course, if you provide information, it's going to be kind of random whether it lowers or raises costs. And incidentally, there's nothing inevitable about comparative effectiveness research raising or lowering costs. It may find that more expensive procedures and more expensive approaches are better. So the idea is the motivation is not so much to lower costs, although for many people that's their hope. The motivation is to make sure that patients get better care, more appropriate care. So the Lewin group, in making its estimates, was actually assuming that this would be embedded in payment systems in ways such as what Geisinger Clinic had done, that they'd use this information to develop more efficient patterns of care. So this is a different set of options than what was in the legislation. This is estimates by the Lewin group done for the Commonwealth Fund, and they showed a bundle of cost-saving features, including these changes in payment, greater use of prevention, effective deployment of healthcare IT, comparative effectiveness, and so on, could yield a $1.5 trillion savings over 10 years. So it could be quite significant. So first of all, what's the bottom line about what reform's going to do? I think you can expect to see a payment overhaul for both private insurance and Medicare. So the rules facing insurers are a little bit strange in some ways if you think that this is designed to lower costs. I'm not going to go into a lot of details, but there is insurance regulation. Not all of it is likely to lower costs. Some of it, many analysts claim, will increase costs. In fact, the guaranteed issue feature and some of the other features to allow people to purchase health insurance without being penalized for their pre-existing conditions and so on, many people believe is sure to raise premiums in the individual market. Despite the reinsurance, despite the other features designed to lower costs, the final legislation has regulations such as the states get to review the medical loss ratio for health insurers, that is what percentage of their premium collections they actually spend in claims payments. So I think private insurers, though, are likely to explore ways to pay for care to promote outcomes just as this legislation is designed to do. The payment changes, if they're implemented, will lead to provider integration. And we could have a long talk about how much is going to happen, how rapidly it will happen. It'll be hard to do in rural areas. All I can say is that once there is a compelling economic case to integrate, they will pay consultants, they will cultivate people to lead the effort and so on. It will not be that hard in urban areas, at least, for providers to integrate if the rewards are adequate. And those of you who lived through the period of the 90s and were involved in hospital care know that there was a proliferation of these organizations, MSOs, IPAs, of course, are still around, and also physician hospital organizations, PHOs, and they were set up to enable providers to take capitation. Providers who had never done that before, they never really took off because capitation never came. But the idea that this means they can't integrate, I think, is wrong. They won't integrate unless there's a big reward for integration. And I just mentioned some of the other regulatory changes in private markets, but I want to turn to what I think is the most important issue for us today. What does this all mean for Medtech? There will be pressures to limit costs of care. So right now, in many settings, the interests of a Medtech firm and of a physician or other provider are aligned in the sense that they both get rewards from doing more and selling more. That may very well change. It's supposed to change. But that doesn't mean, and that's partly because the physicians and hospitals will bear more financial risk, because these changes in payment move us a couple of steps closer toward capitation, though they don't go all the way. What this means is not that they won't use these devices, but it means that they may use them differently. It's possible that different pricing models will be attractive, and I don't want to tell you anything about your business, but you might think about volume pricing models that actually will make more sense. There's already been, for many years, a trend toward greater standardization. For example, hospitals not purchasing as many different models of prosthetic joints. I think that trend will accelerate for all kinds of reasons. But that means that you might want to think about different pricing models. But I want to talk about the opportunities that have very little to do with health reform. The real challenge, I believe, is a little bit outside what's going on in the healthcare system, and it's about what's happening in the greater economy. And many of you have thought about the issues, and there's been a lot of debate about how we'll pay for healthcare. There are no simple solutions. Dana Goldman, who couldn't be here today, and I have a project where we're looking at Medicare reform options, and we're simulating the effects of the different options. There's no magic bullet that by itself is going to change Medicare's trajectory dramatically. There's no single feature. You think about making the whole world more like capitation, it will lower expenditures. That by itself won't be enough. We're going to look at it, undoubtedly a combination of options to try to align revenues and expenditures. But the real game changer is to recognize the fact that Americans are living longer, but we have social policies designed for a different world. Our retirement policies and Medicare were designed in the 60s. Well, the retirement policies have undergone some evolution. But actually, in Western Europe, for example, retirement has been edging down below 60. So, and yet people are living longer. It's not just about healthcare, it's about pensions, retirement, Social Security. We can't really afford to continue to have people stop working earlier.